My name is Joel Ehrenkranz, and I work at the Bada Bing campus of the Tony Soprano School of Hard Knocks. We consider litigation a recreational sport. So I'm going to talk about diagnostics, and I'm going to talk about it in the context of surgery. Okay, so I got back from Tanzania about 48 hours ago. 90% of healthcare in Tanzania is delivered by native healers. So what kind of diagnostics do you need to do general surgery in a place like Dar es Salaam or Goma in the Congo? And Catherine and I sat down a couple of weeks ago, and Catherine gave me a list of what she thought were the essential diagnostics that a general surgeon would need, like hemoglobin. And this, by the way, is a universal reader on the right and a smartphone on the left. And you can buy a smartphone for about $30 in Dar right now, and a microfluidic lab-on-a-chip on top. And that does the hemoglobin for you. And the other thing Catherine said you need is you need to be able to do a white count differential. So that microfluidic device will also create a monolayer, fix the cells, stain the cells, and rinse the cells. And then in the lower right-hand corner, you can see a 400x image taken with a smartphone camera of that peripheral blood smear made by that microfluidic device. And by using an image analysis algorithm, you can do a differential. So you can do a point-of-care hemoglobin, white blood cell count, and differential on your smartphone. Then I think the other diagnostic tests which are key for use in general surgery are sodium, potassium, and creatinine. And taking care of people with acute tubular necrosis is really important for general surgeons because that's like a common complication of trauma. If you need to give them blood, you got to make sure the blood is safe, so you got to know what the HIV status of the blood is and whether or not it's infected with hepatitis B and C. And Catherine told me that you need to be able to do a urinalysis and look for pus and blood and bugs. And again, you can use a microscope based upon a smartphone to do that. And lastly, you need to be able to do ultrasonography. And I hate imaging, but I appreciate the value of ultrasonography. So Catherine has taught me that the key concepts to global surgery are affordability, accessibility, and sustainability. What's the most basic, proven, and accepted way to achieve sustainability? Make a profit. What do you call a sustainable provider of healthcare services? A business. Doing good and doing well are not mutually exclusive. We're going to talk a little bit about malaria. So I thought that I would show you the picture of a college dropout with a trust fund, because this is not sustainable. The bottom line is biology. And again, I want to focus, as an example, on malaria. So there's this big initiative called Affordable Medicines for Malaria. The notion being that if we made the drugs cheap enough, then we could treat this disease. It's interesting that the drugs for malaria are actually a byproduct of the war in Vietnam. Ho Chi Minh called up Chairman Mao and said, the Americans will not beat us, but malaria will. And that ended up in artemisins. So if you want to talk about truly disruptive technology, I think war is truly disruptive technology. Anyway, so let's talk about what happens when you make artemisinin combination therapy, ACTs, really inexpensive. Well, what happens is if you got a fever, you get treated with ACTs. So right now, the Maasai women are right now living to be old enough to go into menopause. The Maasai do not have a word for menopause. It's like a whole new concept. So when a Maasai woman gets a hot flash, she takes anti-malarials. Guess what? They don't work. But what happens is they create drug wastage and drug shortage. They increase the risk of adverse drug reactions. They select for resistance to these drugs. And it turns out that based upon the current prevalence of malaria, that it's cost effective to try to diagnose it compared to just presumptively treating it. So there are consequences of thinking that you can just treat a disease presumptively without doing proper diagnostics. Another example why biology is the bottom line is the impact of bed netting. These are these nets that are impregnated with insecticides that $50 million has been spent to launch them in Tanzania. And what these have done has been to select for mosquitoes which bite during the day. This is like evolution in action. We don't need to go to the Galapagos to see evolution. We can see it right now with bed netting. And the last example of why biology is the bottom line is because of the effects of malarial vaccination. And there are papers coming out now showing that it's possible to vaccinate kids from malaria with about a 50% efficacy rate. This will just get better. So what happens? Firstly, what happens is you create chronic carrier states. So yesterday we heard about that there are two essential diagnostics for pediatric care: a tape measure to go around the humerus to determine whether or not a kid is malnourished, and a rapid diagnostic test for malaria. Well, I don't know if Steve Alder is still here. He's the head of public health at the U. Steve will tell you that in the rainy season in Ghana, 75% of the time, kids test positive for malaria. It's not a false positive test. It's the fact that they're chronic carriers of malaria. And that's what's going to happen when you vaccinate kids. Biology is the bottom line. Kids won't die of malaria. Old people and immunocompromised people will instead die of malaria. Biology is the bottom line. When your only tool is a hammer, everything is a nail. And again, let's use malaria as an example. And I think the best example is a study that was published in the Quarterly Journal of Medicine in 2003, where they looked at 199 adult patients who were admitted to the general hospital, the general teaching hospital in Dar, 2000 to 2001. 38% of those people who had presenting neurologic complaints had an admission diagnosis of cerebral malaria. 7.5% had detectable parasitemia, compared to 9.3% of asymptomatic controls. So in fact, the presence of parasites in the blood was less in people with cerebral malaria than it was in controls. Makes you wonder about the diagnosis. 1% of the patients met the WHO criteria for cerebral malaria. 87% of patients who had no detectable malarial parasites on thick smear of the blood. And trust me, they can do this test very well there. Nonetheless received anti-malarial compounds. Turns out 21% had stroke, and you'll notice that certain terms are in blue, and you'll see why in a minute. 19% had meningitis, 12% had HIV-related disease, 11% had diabetes, on and on. 5% had psychiatric disease. Does anyone in this room remember tabes dorsalis? Tertiary syphilis? 5% had cardiac disease, 1% had other. I know someone's going to say, but that is up to more than 100%. The answer is true, because you could have multiple diagnoses. This is why diagnostics are essential, because then everything is not a nail. Some things might be a screw. Some things might be a staple. Now, I want to introduce a new concept called NCDs, which is supposed to stand for non-communicable diseases, or new concept, diagnosis. Over the past decade, the incidence of malaria has decreased by 50%. This is a business you don't want to go into, because it's a shrinking market. HIV is now considered a chronic disease. Now people are starting to think about taking care of chronic diseases in places like sub-Saharan Africa. WHO estimates that coronary artery disease will double in Africa by 2030. A lot of people in Africa die of cerebral vascular disease. Type 2 diabetes is going to increase by 80% in sub-Saharan Africa by the year 2030. 20% of deaths in Africans currently over the age of 45 is due to cancer. Nobody cares about thyroid disease in the global south, other than to think about iodine deficiency, which, by the way, can sometimes affect over 50% of the population. Okay, so let's just talk a little bit about endocrine disease in Africa. And by the way, this is a lousy picture of a 20-year-old girl with acromegaly. Acromegaly is a uniformly curable disease in the developing world. This girl is dead. Type 1 diabetes, the big complication is ketoacidosis. No one dies of DKA in the United States, pretty much. 25% of people with DKA die in Tanzania. A third of people with DKA die in Kenya because they can't get insulin, because no one thinks of the diagnosis, let alone can do any of the basic labs, because they can't afford the syringes or the glucose strips to be able to monitor the disease, because there's no infrastructure, and because they're just basically sick people with poor nutrition who are susceptible to complications. Type 2 diabetes is a giant problem in the developing South, in the developing world. And even though you're surgeons, you take care of a lot of people with type 2 diabetes directly and indirectly. I have never seen a patient die of hyperglycemic hyperosmolar coma in the developing world. 44% of people in South Africa, which has a very good healthcare system, die of hyperosmolar coma. This is a problem. People say that filariasis, schistosomiasis, trypanosomiasis are neglected tropical diseases. They're not neglected. Thyroid disease is the true neglected tropical disease. In an iodine-sufficient environment, 10% of the population will have thyroid disease. And sub-Saharan Africa is an iodine-insufficient environment. So, what lessons have I learned that I can impart to you? Firstly, this is a picture of Malago Hospital. And I think one of the earlier speakers mentioned the Malago Foundation. You know, the M-U-L-A, the G and the L fell off the sign. The clinical laboratory at Malago Hospital, which is about 1,100 bed general hospital, generates results which are worthless. The reason being because the lab technicians take the reagents and sell them on the black market and make up results. I know this blows your mind. When I learned this, it blew my mind. So lesson number one, you will be scammed. You will be scammed. Lesson number two, this is a picture of a woman in the eastern Congo checking a thick smear for malaria parasites. You know, there are three technologies which haven't changed in a long time: the microscope, the wheel, and the sail. I think that's interesting. Diagnostics supplement clinical judgment. They're an arrow in your quiver. Use them appropriately. The last slide, these are two 4-year-old kids. And this is on the border of Uganda and the Congo on Lake Edward in the Rift Valley. And the guy on the left is the only chubby child you'll ever see in sub-Saharan Africa. And for those with some knowledge of pediatrics or neurology, you'll notice that he has an ataxic gait. You'll notice that he's short, obese. He has a big, thick tongue. He has swollen fingers. The thing in his right hand is the mallet that we use for hammering in the tent stakes. So this kid has cretinism. Cretinism, congenital hypothyroidism, does not exist in the developing world because it is so easy to diagnose and so easy to treat. I can't tell you how cheap it is to eradicate this disease. But it's not happening because, I don't know why. But it brings the point is that basic health care, as opposed to medical care, is a fundamental human right. And Ray mentioned my dog. And when I told Ray and Catherine the story of my dog, the point I wanted to make was that our job is to be the voice of people who have no voice, of the kid with cretinism, of the old, of the elderly, of the infirm, of the ill, of the people who are disenfranchised. And that, to me, is like really cool and really fun. Thank you very much.